and he's a lead expert, and he's actually a regional manager for ECMO program within the city of San Diego. So thank you very much for your attendance, and we would love to learn from you. Thank you.
Thank you. Can you guys hear me? Yes, okay. So today I'm going to cover the ins and outs of ECMO with you. It's a little bit more of a step back and broad overview of ECMO. Just by raise of hands, how many people in this room have taken care of ECMO patients? A lot. Okay. By raise of hand, who is an ECMO specialist taking care of? Perfect. Thank you. Okay. So yes, I'm the ECMO coordinator and lead ECMO specialist at Sharp Memorial. I have no disclosures. Here are our objectives for today. Really describe the modalities of ECMO, the physiology of ECMO, understand blood gases of ECMO, and we'll talk a little bit about vent management, but that's already been kind of covered. And really, I like to highlight that the RT really is an interdisciplinary team member caring for the ECMO patient, regardless if it's an RT ECMO specialist or not. These patients have lungs, they need RTs. I just want to start with definitions in case they haven't been covered. ECMO stands for extracorporeal membrane oxygenation, which is Latin for blood out of the body being oxygenated by a membrane. ECLS, you might hear this term as well. This is an umbrella term. ECMO is a type of ECLS, okay? Non-durable LVADs and RVADs are a form of ECLS. That is basically ECMO without the oxygenator, okay? ECPR, that's kind of in the news and spoken about a lot, especially here in San Diego. That is ECMO being deployed during CPR. That is the definition of ECPR. Blood coming from the patient is the drainage, and blood going back is the return. So why do we do ECMO? We've already kind of covered this today, but specifically it's for DO2, oxygen delivery. This is why we do critical care. This is why we have ventilators. It's all about the DO2, and the DO2 is cardiac output times oxygen content. If you have a cardiac output problem, you need VA ECMO. If you have an oxygen content problem, you need VV ECMO. Mathematically, this is what that looks like, right? Cardiac output, VA ECMO, here's your VV ECMO oxygen content. And as you guys know, the dissolved oxygen in the blood is almost zero contribution to our DO2. So what we care about is the SAT, arterial SAT, and the hemoglobin, right? This is pretty, I think you guys all get this part. ECMO is a bridge. It is a bridge to recovery, transplant, or LVAD. Okay, that's also been mentioned a lot, but sometimes it's a bridge to nowhere, especially with our ECPR population. These are patients during cardiac arrest. We don't know their name, we don't know their age, we don't know if they have stage 4 lung cancer. Get them on ECMO, figure out the problem, and if we can't, it's a bridge to nowhere, and that's where we have a different kind of conversation. Comfort care, right? What makes up an ECMO circuit? Cannulas that are placed in the vessels, a pump to generate flow, an oxygenator to function as the lung, a blender for us to control the gas going to the ECMO machine, and then we also have a heater to regulate blood temp, because whenever you have blood flowing out of the body, the room temperature is pretty cold and the patient will become hypothermic. So we're going to break down those right now. So our cannulas, we have venous cannulas that are the long ones. They're often multi-stage. You can see they've got holes throughout the tip. And then what we call a single-stage arterial cannula or return cannula that are shorter. This is what it looks like in a venous cannula that's placed in the IVC, RA, or SVC. Depending on physician preference, they can be placed higher or lower. I would say ideal positioning is tip in the SVC, because the majority of the flow is being sucked into the cannula by the lower side ports, not the tip, okay? And this way you're draining most of the blood that would be going into the heart. And this is for a VA ECMO configuration. We'll talk about the placement in a second. We also have dual lumen cannulas. There's different sizes, shapes, and forms, but this is a single insertion site that is bifurcated inside. So one point of insertion, we can flow out of the body and then return the blood oxygenated into the body. This is what it would look like placed. This would be a crescent or avalon for VV ECMO. You can see here, we're gonna suck the blood in through the upper SVC port as well as the lower IVC port. It's gonna go to the ECMO machine, come back and shoot right at the tricuspid valve, oxygenated blood straight to the heart, so that it can get through the heart to the brain, which is the goal of the oxygen, right? This is a Protect Duo, kind of similar to this, except it actually goes through the tricuspid and pulmonic valve and sits in the pulmonary artery. So this is called VPA ECMO, or just an oxy-RVAD. We also have central ECMO. I don't think we've spoken about this today yet, but central ECMO, this is usually done by, obviously, cardiothoracic surgeons during in the OR for patients that cannot come off cardiopulmonary bypass. This is typically what it looks like. You're looking down at the patient's feet, right? Here's your aortic cannula, your right atrial cannula, and then there's other cannulas in this picture. Cardiothoracic surgeons are very good at putting cannulas into all different kinds of holes in the body, and if there's no hole, they make a hole, and then they put the cannula in. And the bedside nurse half the time struggles like, where are the cannulas actually going in? Because I see it's here. I don't think it's in their stomach, right? So they have to know actually anatomically in the heart, where are we connected? So the pumps, there are many different companies that make pumps. These are just some of the most commonly used. This is the CardioHelp. This is the Rotaflow. We also have the new Medtronic VitalFlow, and Spectrum makes a Quantum. Essentially, these all do the same thing. They spin a magnetically levitated centrifugal pump to generate pressure, which generates flow. Like all pumps, they are preload dependent and afterload sensitive. That is an important component for ECMO, because if you don't have volume, are we going to flow? No. And what's going to limit our flow is how much volume we have in those vessels to suck out. Because you can imagine flowing 7 liters per minute, which is usually the max, you have to have some blood in your body, right? We're not going to go over the physics of the pumps, but just know that they're magnetically levitated and they spin. One thing that's just unique about these pumps, I will say, is if you have a patient on ECMO and you clamp a line on the ECMO, this pump is still spinning at the RPM that you designate. It does not stop. It's not like a roller clamp pump. Those will just blow the tubing off, okay? So the oxygenator, kind of the bread and butter of the machine, right? This is what's allowing blood, the diffusion of gases from the sweep gas and the blood. So obviously the oxygen concentration in the sweep gas, it can sometimes, we have it on 100%, so it's pure oxygen. CO2 in the blood, obviously a much higher gradient because there is none in the sweep gas, right? Medical air does not have CO2 in it. CO2 rapidly diffuses compared to oxygen in the membrane, just like it does in the alveoli in the lungs, right? The sweep gas is proportional to the CO2 removal, and you've heard that a couple times now. Think of that, that's your respiratory rate or your minute ventilation. You increase that, you remove more CO2. You decrease it, you increase the blood CO2. Increased sweep does not provide more oxygenation. That's a key thing to remember too, because often people want to increase the sweep gas to deliver more oxygen. The oxygen delivery increases when we increase the ECMO flow, okay? This is what they look like. These are some oxygenators. This is what the gas inlets look like, and they all have outlets, and this gas is flowing constantly. You will often see condensation coming out of these ports because gas is cold compared to the blood, forms condensation, and that blows out the bottom. So that's normal. This is what the membranes look like. If you were to open this oxygenator up, this would expand to a huge size, and it's compressed. You've got millions of pores like this, where blood flows through, gas flows the other way, and then you also have water flowing to maintain temperature. Pretty remarkable, the technology and how this has progressed over time. Blenders. So this allows us to control what the sweep gas is, okay? We refer to this as FDO2 or FSO2, so delivered or sweep. Even though it says on here FiO2, that's wrong. FiO2 is your vent, that's your inspired oxygen. At our institution, we do not blend the oxygen. So our ECMO machines are getting 100% pure oxygen. A lot of places will blend it and drop it to like 80%, 60%, because to prevent hyperoxia. But the data's kind of not out yet. I don't know if you guys have read the new blender trial that came out, but. So configurations, VA ECMO. So V to A, right? We're draining the veins and we're flowing back into the artery in a retrograde fashion. This is cardiac support. Okay, we spoke about where it's draining. Most of the time this is peripheral, right? Central for the OR. So what's important here is VA ECMO supports systemic circulation, but what's its effect on the heart? It can actually harm the heart, right? We're putting this on because the heart doesn't work. But that intervention, it's a life-saving intervention, is not great for the heart. That is pure afterload for the heart. So the heart's already injured. Now you put them on VA ECMO, you've got retrograde blood flowing up the aorta, making it even harder for that heart to eject. Okay? And keep that in mind when you're looking at your hemodynamics and your PA pressures, right? It's going to be altered, right? Your PA pressures are going to go down as I take blood out of the body, less blood's going through the heart. This is an important concept. When you're on VA ECMO, you have two circuits in parallel. One circuit is my ECMO machine that I'm controlling sweep and FDO2. The second circuit is the native heart and lung. This is not cardiopulmonary bypass, okay? That is very different than ECMO. In cardiopulmonary bypass, there is no heart and lungs. It's one circuit. So this is more complicated than cardiopulmonary bypass in that aspect. And because of this, you get dual circulation, which I know we've spoken about already, but this is a byproduct of having parallel circuits. This is exacerbated by very low-placed femoral drainage cannulas, and it's also dependent on the native cardiac and lung function, as you guys have heard. So dual circulation really presents in two ways. You get differential oxygenation or differential carbon dioxide. That's kind of the updated nomenclature from ELSO. When you have differential hypoxemia is a kind of differential oxygenation, right? And this is previously what was called Harlequin syndrome or north-south. So given you guys have the answer to this question, why is this differential oxygenation not seen in centrally cannulated ECMO? Can somebody tell me? Exactly. In peripheral VA ECMO, you're returning retrograde up the aorta, but in central, the cannula is placed in the ascending aorta. So there is no mixing point. Great. I'm actually going to skip this video that shows a little bit about the mixing point because we've kind of covered it throughout the day. But this is your aortic anatomy. And just like you said, the ascending aorta is cannulated in central ECMO, which means that if I draw blood gases off the right radial, left radial, or FEM, it's the same ECMO blood. No mixing point. Although that's not really true. There is a mixing point, and it could be right here at the coronary sinus, right? But there's no way to check that. So always right radial ABG, right? Because the right radial comes off the right carotid, the right brachiocephalic, which is the first branch of the aorta. Does that make sense to everyone? Because that is very important. Now, what do you do if you can't get a right radial, right? We have many patients that they might not even have a right arm. They might have an AV fistula. What are we going to do? We're going to go left. And we're going to use some transcutaneous monitors to measure tissue oximetry bilateral. And that will give us a clue to a change. Okay? And like I said, this does not account for what's coming out of the coronary arteries. So VV ECMO. VV ECMO is really only pulmonary support. So if you have cardiac dysfunction, VV ECMO is not going to help you unless your cardiac dysfunction is due to hypoxia, because oxygen is a very good inotrope. Okay? It is important to understand the shunt fraction, right? This is the percentage of the blood that's captured by the ECMO, right? So you have a young patient that has a hyperdynamic heart with a cardiac output of 12. I might max my VV ECMO out at 6 liters per minute. I'm capturing 50% of his blood. He will not have a SAT of 100%, right? So always understand that, as well as the mixing, which is the efficiency of the circuit. On VV ECMO, both cannulas are where? In the same vessel, right? Where they're placed in the same vessel, if they're put right next to each other, what's going to happen? It's just going to recirculate. And you'll see some pictures in a second. But if you're recirculating, you don't have a very efficient circuit. You want those as far apart as possible to prevent recirculation. Does that make sense? Okay. So the configurations for VV ECMO. So there's 3 main configurations: FEM-IJ, FEM-FEM, or the dual lumen cannulas. FEM-IJ, for us at least, this is the preferred method. You can have the highest flow and the least recirculation, right? But you do have to place an IJ return and a FEM drainage. FEM-FEM is great for emergent procedures. If a patient's peri-arrest CPR, you can't place an IJ at the bedside during CPR, and it's very risky. Dual lumens are great for mobility because it's just one cannula coming out the neck, but there are limitations to its flow. You're sharing the lumen between 2 cannulas, basically, and it's very prone to mispositioning. And if it gets moved, even by just a couple centimeters, the recirculation can go up to 60%. So VV ECMO, unlike VA ECMO, is 2 circuits that are in series, not in parallel. Therefore, you don't have dual circulation, right? So again, you've got your venous blood in the IVC going to the ECMO machine, which I can control with my sweep gas. That gets put back, comes out oxygenated, back into the same vessel, IVC, SVC, RA, where you have the blood that wasn't captured by the ECMO, and that goes into the native cardiopulmonary circulation. Now, the X here represents a true ARDS patient. So you have to look at your patient's lungs and function. The vent might still be working and doing something. What is your patient's tidal volume? Where are they in the course of their ECMO, right? If your patient has a minute ventilation of 3 liters, be sure your PEEP and your FiO2 are doing something. But if this is a fresh, true ARDS patient, like a COVID-19 patient, your tidal volume is 5 mLs. Is your vent doing anything? No. You could clamp that ET tube and it wouldn't change your blood gas, right? So always keep in mind, is this functioning or not? So here's an example just to show you how we change the oxygenation and really the shunt fraction. High flow ECMO is going to capture more deoxygenated blood and oxygenate it. If we reduce the ECMO flow, more of that deoxygenated blood gets into the heart. Does that make sense? So flow on the ECMO changes the oxygenation. Sweep is the CO2 removal. And that's kind of like why I don't like it's called an oxygenator. Why is it not called a carbon dioxide removal machine? Because it does that very well. And it's equally important to the oxygenation. So DO2, VO2 ratios, I think you guys all know this is RTs. This is what we're looking at when we have these patients. Some centers will calculate this every morning. What is my patient's DO2, VO2 ratio? Because as that ratio gets closer to 2 to 1, we start producing lactic acid, right? End organ anaerobic metabolism, etc. We do not want a low DO2, VO2 ratio. Here's recirculation. So recirculation is going to occur, like I said, when those cannulas are placed too far. This is a very bad X-ray. Here is your IJ cannula tip. Here is your venous drainage cannula tip. They're 15 centimeters apart. So they're not mixing. If this tip was very close to there, now you're just mixing the 2. And we can monitor this. How do you monitor this, right? So you can see your patient's ABGs are not going to be very good. But also, we can test the pre-membrane blood. So we run a VBG on that blood, and if that VBG comes back with a SAT of 97%, you're mixing. That's not a normal venous SAT, right? So my goal is to have that pre-oxy SAT be closer to a normal venous SAT, okay? But the other thing to keep in mind when you're doing these blood gases on pre-oxy is these are different. We call them SVO2s, but it's not a mixed venous, right? That's from a pulmonary artery catheter, right? So a lot of the time, what is the normal difference between an IVC venous blood and a mixed venous? Anybody want to venture like a number that they think the difference is? No guesses? I'll tell you, on most of these VA ECMO patients that I see, they can be 20%. So if your ECMO machine shows you that it's 95%, don't worry, your patient's not necessarily in septic shock, right? get the pulmonary artery catheter sat, and it might be 65%, which is very nice for a VA ECMO patient. So I'm not going to read the slide to you, but hypoxemia during VA ECMO, what can we do to fix it? Again, what is the shunt fraction? Are we recirculating? What can we do to change, to fix recirculation? What's the intrapulmonary shunting occurring, right? How do we improve, right? Increase the blood oxygen content, right? ECMO flow. Transfuse blood, right? What's the standard transfusion parameter for patients in the ICU? 7. Is a hemoglobin of 7 going to give you the DO2 that you want for a VV ECMO patient? No. So at our center, I got them to go to 8. Baby steps, right? These patients need 10, right? If my hemoglobin was 9 right now, I'd be pretty bad, right? Decrease the recirculation, decrease oxygen consumption, right? Your patient's awake, kicking, fighting the ventilator. They don't have the DO2 to support that kind of energy expenditure. Sedate the patient appropriately. And this is the battle that we have, because we also want to mobilize and walk the patient. But we also don't want them consuming. So it's like this battle between wake the patient up and extubate them, and can we actually have a SAT that's perfusing their brain? And then lastly, we don't do this, is manipulation of cardiac output. And like Dr. Odish had mentioned, this doesn't fix your oxygen delivery. This just reduces your consumption artificially, right? I give a beta blocker, now their cardiac output matches my ECMO flow, and they're satting 100%. And now they go into RV failure, and the beta blocker works off. This is kind of like the last-ditch effort that I would say is more reserved for like a very young patient that's just very hyperdynamic that you want to just subdue a little bit. But use with caution. Lastly, I just want to mention some other configurations, such as VVA. These might be referred to as VAV. You can kind of move the letters however you want. The point is you're a patient that's on a hybrid ECMO. So these are typically your VA ECMO patients. They come in, they go on VA ECMO. All of a sudden now they're hypoxic despite your VA ECMO. We're going to add a third cannula and put them on VAV. And all we're doing is just bifurcating the return line to the vein and the artery. Okay, so it's shared. It requires different flow measurements to figure out how much is going to this cannula, how much is going to that cannula. And we use special clamps to just direct the flow according to what we want and to maintain the SAT, right? Because VA ECMO will not help your lungs, right? Circuit assessments. When you're in the room, again, whether you're the RT ECMO specialist, anybody going in that room, you should be looking at your cannulas, at the tubing. Is there color change, right? This is what it should look like. Dark venous blood and bright arterial blood. All ECMO should look like this, okay? There is one kind of ECMO that doesn't look like that, but we'll save that for another talk. Recirculation, this is what it looks like. They're both bright red. That is not normal. And if they're both like this, you might have a problem. Or maybe your patient's about to come off VV ECMO and we turn the sweep to 0. And that's what it looks like. And the blood's just moving. Because you can't stop the blood flow, it will clot off, right? So that's the beauty of VV ECMO, is we can actually go to sweep of 0 and see how the patient does without ECMO. And if they do well for 24, 48 hours, we decannulate and they do great. VA ECMO, you can't trial prolonged off ECMO, right? Fix. How many of you guys love fix? Everybody does fix here, right? Yes, I hear the sighs. Do you guys count it down, 1, 2, 3, and draw at the same time? Yes? I can't stand it when people do that in my hospital. So the Fick equation, right? This is how we figure out what's going on with this patient. What is their cardiac output? Okay? I'm not going to go into the math here, but you can see what are the variables here. The only variables that you guys measure is the CaO2 and the CVO2 difference, which are done by drawing a mixed venous blood gas from the pulmonary artery and an ABG at the same time, and then plugs it into a mathematical formula, and you get a cardiac output, right? Because again, here's the same DO2. This is the important thing that we're doing, right? We need hemoglobin to carry oxygen to the tissues. So how do FIX come into play with ECLS now? This is important. On VA ECMO, your mixed venous sat is a reliable number. Okay? The nurses are doing thermodilutions as well as CCO swans. So these are special pulmonary artery catheters that we can measure. This is what it looks like. This is a thermodilution swan. Are you guys all familiar with these swans? For those that aren't, we're going to inject room temperature saline into the pulmonary artery. The tip of the catheter is going to measure the fluctuation in blood temperature and the amount of time it takes for that temperature fluctuation to return to baseline. Think about it. The faster that the blood temp returns to baseline, the faster blood's moving through the pulmonary artery. It uses mathematical algorithms to give you a cardiac output. Now, on VA ECMO, why would that not be a reliable indication for cardiac output? Think about it. I inject, for those of you that have seen this, when you inject the saline, it's going where? To the right atrium. Where's my drainage cannula sitting? Right atrium. I put room temperature saline into the patient. This software uses a mathematical algorithm to see what 10 or 5 cc's of saline does to the heart, except my 10 cc's of saline goes right to my ECMO machine, warmed up and shot up the aorta. This pulmonary artery doesn't see anything. That's why be careful with thermodilution swans, okay? CCO swans, these are thermistors that are inside the right ventricle that can heat the blood up by fractions of a degree and measure the same temperature fluctuation. These can be accurate, but just remember you're only measuring the native blood flow, not the ECMO flow. So if that says 1 liter cardiac output, it probably is. VV ECMO, this is where I see a lot of mistakes happen. Mixed venous blood gases cannot be drawn on VV ECMO, right? Does Y make sense? I'm putting oxygenated blood into the right atrium, which then goes through the heart to the pulmonary artery. These mixed venuses can be 99 or 100% sat. Those are not your patient's mixed venous sat, right? So thermodilution swans will not work for the same reason as VA. CCO swans might be accurate, but the most common way is a flow track, and that is a device that we put on the art line that also uses mathematical formulas to calculate what the cardiac output is for VV ECMO. Okay, but you cannot have a balloon pump, and there's a bunch of other excluding factors for use of a flow track. But does it make sense why you cannot get mixed venous and why you can't do FIX on a VV ECMO patient? Any questions on that? Okay. RVADs. So again, I don't talk too much about RVADs, but RVADs are basically your mixed venous and your FIC will be reliable because you're not manipulating the oxygen content of the venous blood. AV fistulas is something that people, I think, forget about a lot. And I see this. I've seen many patients where you come in the morning, the patient looks horrific. The lactate's 15 now. They've been doing FIX all night, and the FIC cardiac output says the patient's not in cardiogenic shock. They have an AV fistula flowing 2 liters per minute. That's basically the same as VV ECMO in terms of your FIC. Your FIC is wrong. Your patient's in full-blown cardiogenic shock. They're now on VA ECMO, and they don't do very well because it was too late. They deteriorated overnight. Make sense? Okay, rescue vent settings. This is safety. So this is a picture of our rescue vent settings sign and our order set. For any patient on VV ECMO, this is at the bedside over the ventilator. Your center might have different settings. That's fine. I'll be honest with you, these are cookie cutter settings. In an ideal world, each patient would have their own customizable rescue vent settings. But it's better than nothing, because if your patient has a tidal volume of 5 mLs on pressure control, 10, 10, 10, and my ECMO machine just turned off, how's your patient going to do? They're dead, fast. You're going to put them on these rescue vent settings. Now, if your tidal volume's 5 mLs on pressure control and you put them on these rescue vent settings, what do you think you're going to do to them? Bilateral pneumos. They're probably going to die from the rescue vent settings. But this is a last-ditch effort to buy seconds so I can get the ECMO machine back on. And if I can, I've just averted a code blue. If I can't, now you're a code blue. And in a code blue, rescue vent settings go out the window because you're going to put them on an ambu bag, right? So that talks about, now I go into code blues on ECMO, right? VA ECMO, it is only a code blue if I cannot flow. And I can't stand this when I come in and I hear that they called a code blue overnight because the patient went into VFib and the ECMO flow was 6 liters. There's no code blue. There's no CPR. Defibrillate them. That's it. VTVF, shock. Notify the doctor, right? It is not a code blue. You don't need everyone showing up to the room. If the ECMO can't flow, that is a code blue, okay? VV ECMO is a code blue because you do not have cardiac support. Does that make sense? So if your VV ECMO goes into VTVF, that is a code blue, okay? And at our center, this is sometimes I have to remind people because we do 90% VA ECMO. So everyone just knows ECMO is not a code blue. Then you got a VV ECMO patient that goes into VFib. No, guys, this is a code blue, okay? And all codes ambu bag. Okay, blood gas monitoring, right? I drive my RTs nuts. Every morning, we draw 4 blood gases on every VA ECMO patient. Standard orders. I want a pre-oxy blood gas, right? That's really for me to calibrate my machine. Because on my ECMO machines, I see what the SAT of that venous blood is. I see what the hemoglobin is. So that's for me to calibrate. I get a post-oxygenator blood gas. I'm looking at a couple things. I want to know what is the oxygen content coming out of my ECMO machine. But not only that, I want to know what my CO2 is. That ECMO machine is another pair of lungs. How can I not get a blood gas to know what those lungs are doing, right? I get a PA cath mix venous, and I get a patient blood gas. And I use all of these for rounds to figure out where is that infamous mixing point, right? So here's some examples. These are actual patients' slides that I've taken here, okay? Here's 5:09 in the morning, patient blood gas. Can you guys see these numbers? Okay, patient blood gas right here. And here is my ECMO post-oxy blood gas. And what gives it away that this is post-oxy other than my comment right here? My PO2 of 400, 500, 600, right? Typical on a post-oxygenator gas when I'm flowing 100% FDO2, okay? So what do you guys think of this patient blood gas? Huh? Hypoxic. Yeah, that's not good, right? That's a problem, right? pH is fine, CO2s are fine. Where's the mixing point in this patient? What do you guys think? Is it in the ascending aorta or the descending aorta? It's in the descending aorta, right? This blood gas came off the innominate, right? Now, in this case, the patient's on 70% FiO2, so I can do some vent work. But if I can't fix this, VAV, right? I have to treat this hypoxia. Now, some people say, well, why don't you just turn up your ECMO flow and push the mixing point here, right? Would that fix the blood gas? It would. If I increase my flow and push this here, my patient PO2 would go from 31 to 439. Did we fix the problem? Did we fix the patient? No. We've now shut the aortic valve, and the left ventricle is not ejecting. And now we've got thrombus, and unless this is a transplant patient, this patient will die, right? Okay, here's another scenario. Look at this one. This is your patient's blood gas at 4 in the morning. Here's their post-oxy, right? Where's the mixing point? This is easy, right? Look at the PO2s, right? The mixing point is here. My radial A-line blood gas is the same as my post-oxy blood gas, right? Is this heart doing well, you think? And there's other methods, right? This is just one method of looking at this. You also have your A-line tracing, your end-tidal CO2, all these other things that we've mentioned today, right? So we know this patient's not doing good. They probably don't have a good pulse pressure and a flat A-line. 7:45 in the morning, look at my patient's blood gas. Right? Look what happened. The mixing point shifted. my PO2 went from 496 to 112. And I'm still on 40% FiO2. So in this actual true scenario, this is what happens when a stunned heart wakes up. We did no intervention. No Impella placement, no inotropes. This was a heart that woke up post-arrest on its own. Okay, I wish I had the A-line tracing to show you like the correlation, but you guys can envision that. Pretty cool, right? So I always tell my specialists, where is the mixing point? Because that tells the RTs and everyone in the room, which lung do I want to manipulate, right? In the past, we would just always walk in the room and everyone would just be like, it's the ECMO, it's the ECMO, it's the ECMO. No, it's not. If this patient was now hypoxic, how are we going to fix it? ECMO or vent? The vent, exactly. But here, if my CO2, like look, I've got a little hypercarbia here, but I've got a normal pH. This is a fine ABG. But if this was respiratory acidosis on this patient blood gas, how are you going to fix it? Increase the sweep, exactly. How am I doing on time? Okay. Here's a quick little case study, okay? Patient day 1 of ECMO, you're on 3 liters of sweep. FiO2 is 100%. Here's your ECMO screen. You can see I'm flowing 3 liters here. SVO2, patient's satting 80%, but their sat goal is 85%. What are we going to do? Say it loud. Increase the flow, not the sweep. The sweep will only affect your CO2 removal, right? Okay, here's a dual circulations case study. 48-year-old woman with interstitial lung disease and pulmonary hypertension, acute on chronic hypoxemic respiratory failure, and RV failure, okay? LV functions normal. She gets placed on VA ECMO, tons of fluid, wet lungs. Now you got pulmonary edema, terrible oxygenation, and your right radial ABG is 736, 53, and 66 PO2, right? We're maxed out on vent settings. What you gonna do? You're definitely gonna diurese her. What can I do from an ECMO perspective? What's that? So I can't just increase the flow. This is VA ECMO, right? Increasing flow is just going to push that mixing point up. Anybody? So the sweep, I'll take care of this 53, right?
But not the
Wait, will it take care of this 53? This is ventilator, right? This is an example of dual circulation. The only way to fix this, the CO2 is not the problem. The pH of 7.36 is fine. I have an oxygenation problem. This patient is a VA ECMO patient that now has terrible lungs.
increased peak.
Yes, but now you've done your vent stuff and it's just not, you can't fix it, right? Because it's an ECMO lecture, not a, right? VAV, place that third cannula in the IJ and bifurcate your return so that you're providing cardiac support, but you're also putting oxygenated blood into the vena cava, and now the PO2 comes up. Does that make sense? Okay. So I just wanted to show you a picture of, I mentioned RVADs, LVADs, and BIVADs. These are extracorporeal VAD circuits. Don't get confused if you see these circuits. They look like ECMO. There's no oxygenator. And I see this happen a lot in our institution where people think that they're on ECMO, right? They're not on ECMO. So when they go to cath lab and they start desatting, it is a problem, right? And I just want to show the hard work all pays off with our actual patients. These are some patients, VA ECMO, got a heart transplant. This is a lady who gave birth, this is recent, gave birth at our women's hospital, postpartum, massive pulmonary embolism, cardiac arrested in the NICU with the baby, placed on ECMO right then and there, and left with baby. And some of our ECPR survivors as well. So that's all I have for you guys. Any questions? Any questions? Okay. Thank you, guys.